You are listening to the Iser Health Podcast with your host, Dr. Josh Gilden.
Disclaimer. The information discussed in this podcast is for educational and informational purposes only. Always consult with a qualified healthcare provider regarding a medical condition or treatment. The views expressed by the guests and hosts are their own and do not necessarily reflect those of any affiliated institutions.
Dr. Scott Schames.
Dr. Gilden, what a pleasure to be here.
Pleasure's all mine. Welcome. We're going to break the fourth wall down, right? We tried this once, and it was an epic failure. No, it wasn't an epic failure. It was fantastic, but there was a technological failure.
That's all right. We're at it again.
At this point, it's been so many months, I can't even remember the conversation. It was a great one. I just can't remember most of the details, and I can't share any of them with the audience. So here we are again.
Thanks for having me back.
Welcome to the Iser Health Podcast experience again for the second time.
Number two.
So what the viewers missed out on, and what we'd like to inform them about, is a little bit of your history in orthodontics,
Of course.
and kind of your journey, which thankfully I remember some pieces, but I don't remember all of it. So I'd like to go through it again if you're okay with that.
For sure.
And also, give them a little bit of a rundown of what to expect with orthodontics. I was thinking actually on the way in that so often in medicine I am performing like ameliorative procedures, like something to ameliorate discomfort temporarily, right? But I don't get restorative. Like that's not my component of medicine is not restorative medicine. I don't get to, like I imagine for you get to see a mouth, you see teeth. They're not perfectly aligned, crooked, they're hitting each other, the patient's uncomfortable. And by the time they're done with the process, having been someone who actually went through that process, you can look in the mirror and have a smile that you're proud of. So I imagine there's a lot of gratification in that, right? So what made you think about orthodontics?
So I've always been fascinated by orthodontics since I was a child. I mean, I grew up in a home where my father is a dentist, my uncle, my first cousin's a dentist as well. So dentistry was a very big part of my upbringing. And then I always knew from the beginning that I loved working with my hands. I mean, just going back a few generations, my grandfather was a shochet. So he was very busy with his hands day in, day out, a different type of work. My father, I
hope you don't wake up confused on any day. Am I my grandfather? Who am I again? That'd be terrifying.
No, Baruch Hashem, I'm able to do what I do on a daily basis, and in the community, I'm able to do it in. So yes, my grandfather, then my father, he saw that growing up. And he had a love for working with his hands and helping other people. I think that's the real key. And I saw that too, how much gratification my father had from helping other people, getting them better. Similar to you, my father has more of a specialization in like oral facial pain, TMJ issues. So people are coming to him in pain or they have an issue. And he, like you, is looking to get them out of that pain. So when it came to me, I saw that aspect. When it came to orthodontics, I saw the aspect of working with my hands. But what I love about doing what I do is the fact that, like you said, is you come in, when you start, teeth are all over, and teeth need help. They need help. And through treatment, which could be anywhere from 2 to 3 years, I'm able to see that progress and get them to the end and hopefully allow them to smile the whole time. But it really comes down to there's a lot of thinking, a lot of thought process, especially when someone comes in, they say they want braces or their dentist says they need braces. It's up to me to kind of put the pieces together. It's like a puzzle, is figuring out how to get them to that end goal. As we know, we say sof maaseh b'machshava techila every Friday night, is we have to envision the end goal and then we have to plan accordingly. So that's what I love, putting those two together, using my mind. Everyone is so different. Their mouths, the occlusion, the bites. Everyone comes in with specialized needs, and trying to address those needs and also being able to work with my hands. I love it. I love what I do. And Baruch Hashem, in a community where it's really appreciated and where I'm able to make a big impact.
So you mentioned that your father is like specializes in TMJ. It's actually something I've not heard of before when it comes to dentistry. Something that I think is super helpful in general, because I'll see people in acute care and an urgent care setting, sometimes in the emergency department, where they're coming in with, they're not sure what's causing it. It's sudden, they can't identify any risk factors, any sudden change in their activity that might have caused it, but all of a sudden like this, sometimes referred ear pain, or sometimes it's dental, and it's like in that general TMJ, temporal mandibular junction region, right? And I usually refer them to ENTs, I guess, to take care of it. I give them the classic instructions, and just so people know, generally TMJ is related to inflammation and eating chewy things or chewing on gum, right? The more that you exercise that joint while it's inflamed, the worse it's going to be, right? So you say, cut out all the fun stuff in life. No more steaks, no more gum, right? Anything that's enjoyable, you stop doing it right now. And obviously, a short course of NSAIDs usually at the same time, but I've never heard of a dentist who specifically focuses in it.
Right. I think if there was a field or type of profession that would deal with it, is the whole, is a dentist. I mean, dentist is more than just treating teeth. I think it's more of the whole facial structure. When it comes to the mouth, there's a lot of muscles. There's the mandible that moves. It's more, and that's what I get to deal with, is not just the teeth, but also the underlying maxillomandibular relationship, the jaws. Thankfully, I don't see much of that TMJ issue, but I feel like a lot of it comes from muscular origin, because we're using our mouths so often during the day that we're chewing, we're talking, and a lot of it is that referred pain to that joint space area. Yeah.
You mentioned the reverse engineering component of orthodontics, right? You have to figure out what the last image of the smile is going to look like and kind of reverse engineer the steps to get there.
Yeah.
How does that, impact how you view life in general, right? Like I think currently we had the Moshe Wiener, Rabbi Moshe Wiener was here, and he was talking about caffeine and how he'd been off caffeine for 2 years, right? And I thought that was wild. That was insane. I'd never heard of anything like that, and I also thought it's something I'll never be capable of doing.
Me neither. Right.
And here we are drinking tea. All right. Also breaking down the fourth wall. This is tea. I'm 2 months into not having caffeine or coffee.
Wow.
And this is decaffeinated tea, so I might add it has minimal amounts of caffeine.
This is
in
something
there.
I don't think I knew.
This
Good
is
for you.
This is big news. This is big news. And part of it was, just for me, I wanted to, I have shift work, right? So oftentimes I'm short on sleep depending on how the shifts are scheduled. And then, there's various other life factors that impact your sleeping habits. And part of it was like, is it possible to live life without having a cup of coffee in the morning? That was my question. I wasn't sure. And over the holidays, especially when there were fast days, I kind of took the fast day as my opportunity to get clean, so to speak, right, from caffeine and coffee. And every day has just been, well, let's see if I can do another day. And don't get me wrong, I love coffee. I love everything about making coffee and, the finesse in how to make coffee and the ambiance when you sit and get to have a cup of coffee in your special spot. So for sure, at some point, I'm going to have coffee again. It's not a question of whether I'll have a cup of coffee. It's about reintroducing it and changing my relationship with it. So when you mentioned reverse engineering, a lot of times in life, right, we want to get somewhere, right? We have a dream or an aspiration of where we want to be. And what's frustrating is that dream or that aspiration, we're currently not there, right? Otherwise, you wouldn't aspire to be there, right?
Right.
The only way to get there successfully is, I think, reverse engineering, right? If you don't have a plan of where you want to be and then say, well, what does a step right before that one look like? And right before that one, you can't jump the Grand Canyon. You understand? Like, it's impossible. You're setting yourself up for failure. And what's interesting about orthodontics is really it's such a meticulous, slow process. It's a slow grind, if you will, right? And it really, once again, it just translates to life lessons at the same time.
I think it's a phenomenal life lesson. The fact that nothing changes overnight. It's a good process. It's like tshuva if you think about it. You have to take one step at a time. But anything really in life, if you want to make a big impact, you have to take the step by step. It's like the rungs of a ladder. You just climb one rung at a time. You can't jump from one rung to the, 2 rungs. You have to take it one step at a time. But what I do on a daily basis is when patients are coming in, they're already in treatment, is I take a look at where they are right now and envisioning what that end goal is, because we all know we want beautiful smiles, we want straight teeth, we want a good bite. So it's on the spot making a decision, like a game time decision. What's the next move? And so, yes, there is reverse engineering, but there's also thinking about the next step. How are we going to get there at each visit, which is great. It always keeps things lively, fun, enjoyable. And I think the kids like it too. The patients like it. They're seeing wires getting changed. They're seeing different things going on in their mouth. And they were able to really kind of go through the process together. Yeah, which is great.
What have you noticed? Because I was actually a bit older when I went. I grew up with relatively crooked teeth, and it was something that always bothered me, right? And I knew I wanted to be a doctor, and I knew that like the first thing a doctor should do when they walk in a room is probably smile at the patient, show that I'm here for good things, right? Although,
Right.
yeah, there may be pinching and prodding and sticking involved with the process. I'm not here to harm. I'm here to help, and I think a good smile probably helps with that. And I remember, not being able to get braces when I was younger, and then it being a priority when I was in my early 20s. And I did like an aligner therapy where, it feels like it took years, but it probably took in the realm of a couple of years that you had mentioned. And I just remember being so dedicated to the process, right? Because to me, it was so important to have that nice cosmetic outcome so that I could look welcoming to patients.
As a professional, yeah.
Like a professional. Do you notice, because I don't know if you have older patients or younger patients, do you notice like a difference when you take care of the teeth and align a younger patient? Maybe they're taking a little bit more for granted, right? It just, rote, and maybe they're even sometimes more frustrated that they have to go versus, I imagine like an adult who's electively saying, at 20 something years old, I got to go to the orthodontist, get this taken care of. Have you noticed a difference between those visits?
Yeah, very much so. I think it's always great when I see patients that are self-motivated. Teenagers too, young kids. It doesn't matter what age. I definitely do see a lot of self-motivated kids. They want to have a beautiful smile. They want to be able to feel happy, to be happy with their smile, to feel confident, and it definitely helps in the long-term result. The outcome is having that self-motivation. They're able to take care of it, clean better, making sure that not only are their teeth straight at the end, but they also look beautiful. That there's no like any white spots forming, any buildup, plaque buildup, and I do see the results, but it really spans all ages. But it definitely does help when you're older and you're coming in on your own. You're choosing to come in and you're paying for it on your own. Meaning, when we're adults, we don't have mom and dad paying for us. So when you're opting into it, that's in and of itself speaks to the motivation of the person. And I'm sure you took it very seriously. You saw you were paying for it too, and you really wanted that certain outcome. And it looks like you got it. You have a great smile.
There are still things that bother me, so I'll be seeing you after the
No
podcast
problem.
is over. But yeah, listen, I when you go through medical education, you have to take out loans, and you're allowed to take out specific loans for the schooling, and then you take out loans for cost of living, make sure you can buy food, put gas in the car. And I remember, because obviously at that point in time, there were no finances otherwise,
Exactly.
right? I remember taking that money and being like, this is for me, a big chunk of change, right? But it's an investment in my future. It may be an investment that I'm paying interest on right now, actually. So I have to, maybe it's a bad investment. I'm not sure. I got to think about that. But no, it definitely feels good to wake up and know that, you're taking care of your body in general, and your teeth are part of your body. I do struggle a little bit with the aesthetic sense of the significance we place on straight, white, clean teeth. I had Dr. Farkas in that seat, and I was talking to him, and I said, how white is too white? Because I know that society promotes like that someone should be able to open their mouth, and you should have to turn away because it's bleached white.
Right.
And there's you can't, it's so bright you can't possibly look at their face.
That's too much. I get that question all the time. Do I need a whitening? And I show them like your cup. It's a very bright white cup. I said, that's not the natural color of teeth. A tooth has two layers. there's an inner yellowish layer called the dentin, and then the outside layer, which we see as the white layer, called the enamel. And so normal, natural teeth should have that undertone to it. It shouldn't be bright white, but it should be more kind of subtle. And I prefer that more natural look. I don't like that too bright.
Right.
Too bright is not.
Well, at the same time, I wonder if it's a pendulum. I wonder if, because we're still, and I don't know if we are, but I feel like we're still relatively new with the whitening technology, relatively speaking, right? So I wonder if, everyone is jumping onto it because of the aesthetic look, and maybe in 10, 15, 20 years, people are going to look back. I like all the trends that you look back 15, 20 years ago, you're like, oh, that was a little bit ridiculous. Did people realize that was a little bit ridiculous? I don't know. Once again, there's something nice about a straight, white, clean smile, so I don't want to disregard that. But I also wonder when we go from functional medicine to just fashionable, and then obviously fashionable can hurt function, right? Like if it's too white, if you're degrading the enamel too much, that could hurt. That's taking the form over the function ultimately.
Correct. Aside from the cosmetic aspect of going through braces or clear aligners, there's also functional. There's so many benefits to having straighter teeth, a more ideal occlusion, a more ideal bite. I say ideal because nothing is ever perfect. This is the body, this is the mouth. It's all physiological. So it's whatever we're able to make as your ideal, as your perfect. But there's so many benefits aside from that cosmetic aspect. We oftentimes look and see that first thing is that smile, is that nice smile. And I think I want all my patients to be smiling, to want to have that beautiful smile, because I think it does make a big impression. At least for me, that's the first thing I notice when I greet someone, when I see someone. Maybe I'm just trained to see that every time, but I notice when things are not the way it's supposed to be. But with that being said, there is a lot to a smile, and that's our goal. That's what we try to do. We strive to do is, me and my team, a great group of assistants, is we strive to make people smile, and we strive to do it with a smile. So not only are we treating a person's teeth, but we're treating the person. We try to welcome them in with a big smile, making them feel at home, making them feel of the part of the bigger family that we have here. And I think we're able to get that across to our patients, and really, I think they feel it as well, which makes everything so much more worth it. Yeah.
So circling back, you mentioned that you were interested in orthodontics very early on.
Mm-hmm.
But obviously, you don't go straight into orthodontic school. You don't become an orthodontist immediately. You have to do college, right? And you have to do dental school.
4 years.
4 years at dental school. And follow that up with orthodontic training for how long?
3 years.
3 years. So what was the pathway like? Because I know for me, it's a little stressful because a lot of the sciences can be overwhelming. It's very competitive, right? So you have to make sure you're always doing well. You've got to take not only the tests that you take in school. I think I remember at the time, like I was studying for the MCATs, which is the medical test to get into medical school. And beyond just trying to pass my sciences and all the other extracurriculars you're trying to fit in to really fill a resume out. And all my friends are just like not doing any of that stuff,
Right.
Like all of my spare time is spent in my room, sitting at a computer, doing test prep, and they're out like enjoying a summer, I guess, So what was the experience like for you from a college perspective, and then obviously from a dental school, when you kind of see a lot of your peers moving on to their first job, second job, and you're still in the school mode, so to speak.
Right. That's a great question. I feel like I have a different kind of story than most. What I mean by that is, like I was saying, and maybe this is I never actually thought of it. Maybe this is part of why I love orthodontics and why I love what I do, is the fact that from a young age, I knew what that end goal was. I knew that I wanted to be the orthodontist. So like you were saying, I had to reverse engineer, how am I going to get there? So at a young age of 16, I entered college. I started
16?
16. I started community college, so I got a little head start. So
We called Dr. Aaron Herrera. We called him the miracle child. I think we're gonna have to call you the genius child. 16? Wow. Okay.
16, yeah. So I started community college. When my friends were going into 11th grade, I was already taking college courses, beginning my journey, the process.
You needed someone to drive you to college when you were at college.
You know what? Believe it or not, I think for the first few months, I took the bus to college.
Wow.
Yeah, I didn't even have my license, believe it or not. No one knew how old I was. Right. I kept that a secret. Because
did you look old, or?
I feel like I carried myself more maturely. Yeah. I didn't have a beard or
you couldn't
age.
grow one. Yeah, I mean, that would be impossible. I still can't, but I'm working on it. But
no, you grow a great beard.
Please stop.
But it was nice. It was nice to be in a different environment like that. I knew what I was going for. I knew I was there for a purpose. So I went to my classes, did what I needed to do, and then went home. And I was able to spend time with my friends outside of school. And so, like you said, they were doing other things. They were enjoying being a high schooler or doing other things during the summer. I wanted to get a head start. So that was where I started, and then a few years later, I started dental school and going one to another. It was all Baruch Hashem. It was all Hashgacha Pratis. It all came down. Every step of the way was Siyata D'Shmaya. I couldn't have done it without HaKadosh Baruch Hu. And it's amazing being where we are to be able to look back and seeing how every step of the way really was divinely, with divine intervention. Right?
I said on a prior podcast, I was speaking about the medical route, and there's what I call the black hole. It's the Dr. Gilden black hole theory of medicine.
Let me hear this. I'd love to hear it.
Which is, and it's probably a little bit different for you, but I don't know if it's entirely different, that throughout the medical education, there's so many unknown variables, right? I mean, you could study really, really hard on a test and be doing well in your pre-test, so to speak, and then you don't do well in the actual DAT or MCAT, what have you, right? Or, which med school do I get into? Do I have to move across country? Am I going to be around family, right? And then that gets decided. And certainly in the medical route, when you talk about rotations, especially if it's at multiple hospitals, multiple specialties, you're working around every month. You're changing your internal clock to whatever that rotation is and to whoever that preceptor is. And then when you're talking about doing residency, it's, well, which residency? What has my exposure been? Right.
So many unknowns.
Right. Where is that going to be? That's literally a match system. So wherever it is, that's your shidduch. It's essentially your match is made for you, although you do have some input into it, of course, if you do well.
For sure.
But definitely there's a lot of volatility and variability, so it could be tough.
In what way?
Well, you can choose your specialty, right? So I mean, at least you can choose your direction, but sometimes you can't. Sometimes you go for a more competitive specialty, and it just, the cards aren't cut out. You're not cut out for it. The cards don't fall your way, so to speak. I don't think that's an expression, but I made it up just now. Cards don't fall your way. We'll look it up. I don't know.
It sounded good.
Yeah, it sounded good. No, things don't go your way, right? And you end up doing a different field that you hadn't anticipated when you went into medical school, right? That happens to people. There are people that do couples matching, which is when you take a tough, complicated algorithm on how do you match people into specific hospitals and professions, and you have two people trying to match together, and they have thankfully that wasn't a process I was a part of, but it's very stressful for people who it is their process, right? That they have their own rank list, and then they have a conjoined rank list so that they can hopefully geographically end up near each other. I mean, there's a lot of that could be an emotional that's an emotional moment, right? A roller coaster, exactly. So starting for you, you had mentioned that you were doing something that no one around you was doing, going to college when everyone's in 11th grade and probably enjoying whatever they're doing in high school and extracurriculars. And I understand you had a goal, but how did you kind of work through that? I assume you were essentially alone doing your own thing.
Right. I feel like the medical route, there could be a lot more, like you were saying, volatility. Of course, when it came to the dental route too, who's to say you're going to get in? And when you get in and you go through dental school, who's to say you're going to get through it. And if you want to specialize, that you're going to get in. In fact, I wasn't accepted the first time I applied from dental school to orthodontic, to residency. I didn't get in, and it could have been because they saw me as too young. You know, I believe I was.
You were still 16 at the time.
No, by the time I finished dental school, I think I was 21.
A seasoned veteran at that point. Okay.
So what I did a gap year, which I did a general practice residency, which is what a lot of dentists do. To practice in New York, you have to do an extra year outside of the 4 years of dental school to be licensed. So I did that, and then the second time around, Baruch Hashem, Hashgacha Pratis, I got in. But at the same time, it was in Atlanta. It wasn't my first option. I'm from Los Angeles originally, and my wife's from New Jersey, so we wanted to either be in one of those two locations, but it didn't work out. But we went with it. I think being goal-oriented, being determined, and having a good head on your shoulders, from the beginning, and of course being mispalo, davening to HaKadosh Baruch Hu for that help will get you to where you want to go.
I mean, yeah, I guess that's the route, right? I mean, if you're not determined, like truly determined, I remember in the pre-med courses, we start off with like 150 kids, young adults in the biology in the first class, right? And then, I looked around in chemistry and maybe we were down to like 80. And then I looked around in organic chemistry and there was like 20 of us. Where did everyone go? I don't know. But, it was the attrition rate of people that maybe they would have made great dentists and great doctors. But, at some point they kind of realized, the quote unquote, the juice is not worth the squeeze, that the effort that's being put in is not worth the end result. And it was only the stubborn few really that make it through the finish line.
It's a good quality in certain senses to be stubborn, to only want to do that. And I think that really helped. I'm sure, is that what you wanted to do? Acute care, emergency medicine? Is that what you wanted to do from the get-go?
I had an early midlife crisis. Because I was an EMT, and then I was in medical school, and there was an extended period of time where I was, I had gone into medical school with the impression that I was probably going to do emergency medicine. It was something I felt familiar with. I think there is something to be said for staying calm when everyone else is panicking and there's chaos around you. That's probably, if you're going to look at a character trait that you would like to see in an emergency medicine physician or emergency medicine staff, nurses, right? That's an important character trait. So I felt like, that was a good match for me. But at the same time, I started to establish a little bit of a passion for ear, nose, and throat. And, I had done some research in it. I'd spent a lot of time doing rotations. And, I wasn't really sure. When it came out from a match perspective, I was super happy with doing emergency medicine and the lifestyle that meant and the reward that I would get from a career in emergency medicine. And it's a trade-off, right? You're talking about weekends and you're talking about holidays. Versus, a lifestyle that, and it depends. Not everyone's lifestyle is necessarily better if they're an ENT, if they're working late nights and spending a tremendous amount of time in the operating room, which is also, something that I had to consider. So, I kind of knew it going in. I had a little bit of a crisis in the middle, and then I came out on the right side. But like you said, it's a Hashgacha Pratis, right? It's divine intervention. It's being in the place that you're supposed to be when you're supposed to be there. Right. And, we think we have a good idea of what that looks like, and we don't, right? So for you thought that ended up in L.A. or New Jersey, but you took a sabbatical to Atlanta.
Atlanta for 3 years. Right. And you know what? Looking back, were 3 great years.
Can you tell me about Atlanta and your time there?
Atlanta's a great community. It's an out of town community, but really great people. Very tight knit community. The program there was phenomenal. Really learned a tremendous amount, and I feel like I really gained out of those 3 years. And then it was nice to come back to family. That's why we chose to move back in this area, and I think it was all worth it, for sure, all worth it. I think you could agree, through all the ups and downs of getting to where we were, to getting to where we are, you could say it's well worth it.
Yeah, I mean, so I had to go to Florida for medical school. I mean, that was where
Where did you go?
I went to Nova Southeastern University.
Great.
So a little plug for them, I guess. Actually, we have other members of this organization are actually graduates from the same institution, but I'll leave that as a surprise for another episode. It was quality time with family down there. Thankfully, there is family and there is a community as well. And it was nice to get out for a little bit and then to come back at the right time as well. But it's once again, it's commitment. It's commitment to the process, to the job, and there's a lot to be said. To be very lucky to work in the healthcare profession. I was listening to another podcast where the interviewer asked the doctor who was being interviewed, he said, would you recommend it for your children to go into medicine? And I think invariably the answer is no, I wouldn't tell them. I would tell them to do something else. It's too hard. The hours are too long. And the interviewee said, yeah, of course, right? It's such a gratifying job. You don't even get to realize it while you practice it because you take it for granted that your job is, how do I make this person's day better?
Right.
Even if I'm not having a great day, how do I make this person's day better, right? Mm-hmm. There's a lot to be said for having a job like that. Listen, there's a variety of jobs out there that are involved in making other people's days better, right?
Correct.
I interviewed Rabbi Moshe Wiener. His job as a teacher was trying to impact 20 to 30 kids at a single time in a single room and make them enjoy what they were learning in their education. That is a tremendous amount of value. I remember my own teachers who were able to do that kind of stuff. But at the same time, it's an exceptional privilege to be able to go into a clinic and help people in a variety of ways, to go into the emergency department and make such great connections in such short periods of time, especially, obviously when it's critical, but even when it's not critical, to be able to sit down next to a patient and have a nice conversation with them and make them feel like they're being helped.
100%. I think that's why a lot of the professionals we work with are doing what they do. You have to have that love to help other people, to make other people's days better. Part of the reason I'm such a big fan, I love what I do on a daily basis, is that, but also the relationship aspect is that because I'm seeing patients for, more than just you come in, I have an issue, and goodbye, I'm not going to see you. I'm able to see teenagers from when they start and how they grow, how they mature. It's not only their teeth, but I'm able to really create a relationship with the patient. And it's nice to see. And then when the younger siblings come in and they're also, seeing them, and just it really feels like a family atmosphere. And that's probably the biggest satisfaction out of what I get, is that relationship aspect about it.
You were mentioning that, and I thought of two things. I always only think of two things, just for the sake of the podcast. Everyone's realized that at this point it's only two things. But the first thing is that, when I was getting my teeth aligned, it was in a larger shop, so to speak, and there was really not that connection. I think like each time I might have even had a different orthodontist. Like I didn't feel that continuity, which definitely, I imagine when you have it, it's kind of enjoyable, and also you can get a little bit more intimate with, hey, I think this tooth over here, and like maybe course correct, like you were mentioning how you do on a day-to-day basis. But I also remember like there were fish tanks, and like it was all kid oriented. And I do remember like sitting in the waiting room as like this solo 20-something-year-old with all these little like kids on the side, feeling vastly out of place. But once again, it reinforced that I really wanted this because I was willing to sit through such a awkward situation, but it was very valuable at the end of the day. So when you do your residency in orthodontics, what kind of training is that? Is that all office-based? Is there a hospital-based component to what you're doing?
So there are hospital-based programs. Many of the universities have associated with it, an orthodontic program. So you're in a hospital setting, but it's more of an outpatient clinic basis. Where I did it wasn't in a hospital setting. They had two beautiful clinics, orthodontic clinics, with top-of-the-line technology, instruments, and we were seeing patients on a pretty much daily basis. Of course, there's didactic work beforehand. There's, You have to be introduced to the whole field of orthodontics, but you're learning as you go. And you have, as I'm sure you did, attendings who are overlooking your work, making sure what you're doing is correct. But they're also teaching you different modes of thinking, different modalities, different ways to treat. And then slowly but surely, each person develops their kind of way to treat, because there's many different ways to get to the end goal. It's about figuring out what works for you, what's, at least for me, what's the most efficient, can the patient tolerate, and what's the best way. So that's also another aspect of that.
It's interesting because I, from my perspective, I assumed orthodontics was literally all one way, right? Like there's only one way to do it because you got to get your teeth from point A to Z, and essentially it's always the same steps,
yeah.
right?
Right. So it's actually so interesting how many different ways a set of teeth, a mouth can be treated. And I guess that's why orthodontic school residency is 3 years, because it's learning those different avenues, different ways to treat, and then perfecting your own way. Mm-hmm. But yeah, there are different ways. I mean, you go to 2 different orthodontists, you ask them for their opinion, they'll give you different advice as to how to treat the case, how to treat the teeth, the occlusion. But I think what I find is that we sometimes often forget that we're treating the patient. We have to include the patient in the decision making, meaning what we think is ideal and what's textbook, it might not be what the patient wants. They might not want to go through all those loops to get there, even though it might get the best textbook smile or best textbook occlusion or bite. We have to kind of work together. It's a partnership. I always tell patients that I'm partnering with you. As I say to the patients here, it's a shitfist. It's a partnership that I need your help in order to do the best job. So we need to work together and hopefully be compliant where they're able to help me give them and guide them to get the best.
It's funny because in emergency medicine, which is 3 or 4 years, right? It's the same thing where varying attendings have various styles, right? So it's not one size fits all. Should I order you can have 2 attendings in a room and a single patient encounter, and one will order this test and one won't order that test. And it's all based off of a philosophy on how to go about diagnosing a patient, and what requires further evaluation, what doesn't require that evaluation. But like you said, a lot of that is shared decision making, right? So a lot of it is me, right now that I'm the product of that system, is identifying what the patient values, right? And then I can, what the risk tolerance is. When we're talking about emergency department medicine, I can test for an infinite amount of things. I literally have a large catalog, a large menu. Sometimes I say, I'm a waiter and this is the menu, but there's some things that are off menu, right? And, when you have so many things you can test for, right, you have to make sure that you're testing for the right things and you're not going down a path that leads to nowhere, or worse, that could lead to, interventions that aren't necessary and then a poor outcome, right? So you have to be very selective, and it's not based off of what I want to do. Sometimes it's based off my knowledge, certainly, but it's based off of shared. What's your risk tolerance? What are you most concerned about? Those are the things that I can look for. And then I can tell you what we did rule out, what we were not sure about, and how I can get you to follow up. But yeah, it's definitely not one size fits all. And I think in general in medicine, it's not one size fits all, right? When we talk about second opinions, right? It's not because you necessarily don't trust the first provider, right? It's because there's varying, opinions in how to approach things in medicine, and perhaps what that first provider said just did not stem. It did not go with what your opinion is for your own care, and that's the value of a second opinion for sure. You mentioned earlier that you had done the year of general dentistry and now obviously specialize in orthodontics. Is there anything you miss from being a general dentist? Because you did it for a whole year, right? For me, it's like, if I had done 1 year of, general internship and became like a general practitioner, and then I decided, I'm just going to go to the ER and urgent care setting, it would be a vastly different practice. So is there anything you miss?
It's a great question. So it feels
Don't
like
say no too fast, okay? You're going to upset a lot of general dentists out there.
It feels like ages ago, even though it was what
You don't have to date yourself.
it's all right. It wasn't. It was several years ago for sure. But it feels longer than what it actually is, just because I feel like orthodontics, the field of orthodontia, is so different on a day-to-day basis than what a general dentist is doing. You know, a general dentist is, yes, we're both diagnosing. They're diagnosing teeth, caries, gums. We're diagnosing occlusion, and we're both treatment planning and we're both executing. But I feel like what I do is more generalized versus each specific tooth. A dentist is looking at each tooth and saying, does this have a cavity? Does it not? Is there an issue with the gums? But I'm looking at all 32 teeth as a set, seeing how they can work together. And a lot of, whenever you have a person has a filling, the dentist is checking to make sure the bite feels comfortable afterwards. Mm-hmm. So what I'm doing is we're completely changing the bite and making sure that is tolerated. Is the patient okay, comfortable, making sure that comes out well. So a lot of what I do on a day-to-day is not what a dentist does. But then again, you have dentists who do like to get their hands in, to some orthodontics, some clear aligners. But going back to your question, I could say I'm very happy with what I'm doing, and not the fact that I would do general dentistry. Right.
Is there someone who is there a specific patient population that can go to a general dentist for aligners, or is there a specific population that should absolutely be going to an orthodontist? How do you figure that out?
For aligners specifically, or just in general?
To figure, if someone's, let's say just the starting point is they're unhappy with their smile, it's crooked, obviously not being an expert in teeth, they don't necessarily know, is this something a general dentist can take care of or should take care of, or is this something that I should really go to an orthodontist for? Are there any like parameters or any tips you can give someone as to how to make that decision, or always go to your general dentist and see what they say? What would be your advice?
Well, a lot of the times when a patient is coming to me, is they're under the care of a general dentist, because that is primary care. Is dentistry is primary care. So they're being seen by the dentist, and either they ask a question, what about this? Or what do you think about this? My smile, my teeth. And then the general dentist will usually refer to see the orthodontist if they don't feel comfortable necessarily handling the issue. Now, a lot of the times you'll see dentists doing orthodontics or doing clear aligners is when it's more of a cosmetic issue. The patient is fine. There's no traumatic occlusion. They just want to kind of correct the few teeth in the front, minor movements. And then usually if the dentist feels comfortable, they might do it. But I always say it's better to go to someone who does it, the certain thing they do on a daily basis, on a constant basis. Like if, chas v'shalom, someone has an issue with, let's say, their ears, they might go to the primary doctor to see what the issue is, but you want to see an ear, nose, and throat doctor when it comes to actual treatment. That's how I view it.
Shameless plug for your father-in-law, right? I just realized that between you, your father, and your father-in-law, who's an ENT, right?
Right.
When you all get together, I imagine all you talk about is teeth and mouths. Right? There's no other topic of conversation.
I think we try not to.
You avoid. That's work. We don't talk about the mouth when we're...
It's actually interesting. Sometimes my father-in-law will ask me some questions about, about certain teeth, or because not only is it teeth, also don't forget the sinuses right above the maxillary teeth. So if a patient is having issues with the sinus, he'll ask me, or I'll ask him questions about how the relationship, because there is a tremendous relationship between the ears, the eustachian tubes, the oral cavity. I mean, the way HaKadosh Baruch Hu created the whole body is really wondrous, and how everything, as you said, Schames, everything goes together, works, and when it does work, it's beautiful. And it's usually when something doesn't work that they're showing up to you, let's say, or me, or an ENT. But there is a lot of overlap between that, for sure.
We haven't really gone into the functional aspect, because obviously there's a cosmetic component that is not to be belittled, because certainly in today's society there's a value placed on having a nice smile, and we both agree there's something nice about having a nice warm smile. Functionally speaking, what are all the different functionality components to orthodontics and improving I guess the bite, improving the cosmesis of the teeth, as you said, in relation to the sinuses, which are over here? Like, does it help or hurt TMJ? Like, what are all the different components to fixing a smile from a functional perspective?
Right. So correcting a smile, correcting the bite shouldn't really affect the TMJ. There's no real evidence that it does. But a lot of the times we're correcting bites that's to allow the patient to function better, to not only to clean better, to chew better. Think about all the things we do with our mouth, with our teeth. That's we do it, but we don't even think about.
I'm doing it right now, actually. Yeah. Okay.
We swallow, we chew, we breathe. So there's a lot of things, a lot of functional aspects to the bite. And that's what we try to do, is we try to make it more functional. We try to make it more appealing as well.
I guess this is test time.
I see a board.
All right. I'm not sure what the test is, but we're going to test something right now.
Sure, let's try it out.
Now, what would you do about teeth that looked like this? You can see why I didn't go into dentistry.
Do you like teeth? You obviously do. If you
do I like teeth? It's such a good question. Do I like teeth?
And if you do, what do you like about it? What don't you like about it? Because you probably see a lot of emergencies with teeth.
That's a great question. So what do you think of this smile first before I talk about teeth?
a little crooked. I think I can help it out.
How would you adjust this?
Braces.
All right. I think I can get you covered. Hold on one second. See the quality of work that I got here. What do you think? Braces? Good?
Good, yeah.
Right.
You're hired.
I'm hired. All right, very good. Well, that's one more thing I can do. Perfect.
So, Doc, what do you think about teeth? You're asking me. Well, what do you think about teeth? Do you like teeth?
So I'll tell you. There are, I think from an emergency medicine perspective, it's one of those things that we're so limited in therapeutics, right? Like true therapeutics, that we do have like these amalgams that we can like put on top. Right. Well, not even a temporary filling. It's really just to coat the tooth and put something on top, so that the pulp isn't exposed. Right. Exactly. And they can follow up with the dentist, but it's so rudimentary. They always talk about if the tooth got knocked out and it's an adult tooth, you put it in milk. Right, and you quickly get it back, and you don't handle it by the root, but by the crown, which is the top of it, and you try and stick it back in there and maybe like create a bridge. But all of our tools are so rudimentary, generally speaking, that it leaves me unsatisfied when I have patients that come in with a fracture of a tooth, right? And I can give them some pain medication and get them or let's say someone has a really bad cavity, or they really need to get a root canal and they're just having this terrible pain. So I can offer them a bupivacaine shot injection, right, to like a local, right, pain relief. But once again, I guess out of all the different things that I can do to ameliorate discomfort, it's one of the least satisfying things that I can do.
I found that too. When I was doing the general practice residency, that 1 year of being a dentist, I did it in St. Barnabas Hospital. And there we were in a hospital setting. I mean, we had a outpatient clinic, but at the same time, we took call in the emergency room. And so we were oftentimes called, being the dentist on call for, it spanned whether there was a facial fracture, which we used to have to call oral surgery if there was, or if there was like a patient came in with a tooth infection, or they were in pain because of a large cavity. And there wasn't really much we were able to provide for them other than, like you said, some local anesthetic or pain relief. And then we used to tell them to follow up with us the next morning when the clinic was open, because I feel like it's so specialized, the instruments, the materials, that's oftentimes, if you're not really trained to use it, it's hard. It's hard to do in that emergency setting.
Right. And listen, when there's inflammation and there's redness and there's severe pain indicating maybe an infection, of course, we can give a pain block. We can start on antibiotics. It's not insignificant things. It's just not as fulfilling as other components of practicing emergency medicine or even urgent care medicine, where sometimes you do get a little bit more gratification and sometimes instant relief.
What would you say is like your favorite procedure to do, or your favorite type of kind of situation that comes in? And not that it's favorite because it's unfortunate when they do come in with some pain, but what would you say you enjoy doing or get the most gratification out of doing?
So that's a great question. And it's changed over time. And the answer right now is talking to people. And I'm as dead serious as possible when I say that, because when you start residency and when you choose emergency medicine, there are a plethora of procedures that we have to do. If someone's critically ill and can't breathe, we're putting a tube in their throat, endotracheal intubation, right? If someone has a low blood pressure and they need special blood pressure medication, only goes through a special IV that goes in a big vein that is, central line. If someone's heart is not pumping effectively and their heart rate's only 30, you can put a transvenous pacemaker in. If someone has fluid around their lungs and you need to remove it, it's a chest tube. I mean, the list goes on and on and on and on, down to even if someone has a little bit of a fluid infection over here, a paronychia, where we do a little bit of a drainage there. I mean, there's an endless amount of procedures. And when you go into emergency medicine, or the average person goes into emergency medicine, I truly believe most people go into it for the procedures. As time goes on, and I become a little bit more seasoned, I recognize the significance of performing procedures on individuals, right? Especially when they didn't anticipate it, right? If someone came in with shortness of breath and it turned out there was fluid around their lung, and now I'm talking to them about putting a tube in the side of their chest, that wasn't anticipated. And I've said in a previous episode, I said a lot of life is framing, right? What your expectation was relative to what happened. So if the expectation is, I have a little cough, I'm sure it's nothing, let me get it checked out, and it ends up being something significant, then that, of course that affects how you're going to think about it, and vice versa, right? If you thought something was super serious and a doctor gave you a clean bill of health, how relieving that sensation is. But I do recognize that every time I do something to someone, whether it was anticipated or not, it's a big deal. It's even as small as an ultrasound IV, where I put an intravenous line through an ultrasound in someone's vein in their arm, right? It's a relatively small procedure, but it's a big deal, right? It's a big deal to the patient who's encountering it. When I had meningitis quite a few months ago, I do remember the poking and the prodding, and in each one counts. I remember being woken up at 3:00 in the morning for blood draws, right? When you're trying to get sleep and the head is pounding, right? So I can appreciate the value to every procedure that's performed, and nothing makes me happier than not having to do a procedure, and being able to fix something with talking. And by the way, talking is probably one of the most undervalued, and I mean that financially and clinically, aspects of medicine, right? I mean it financially because we all know that talking to a patient doesn't get reimbursed, right? Doing procedures do, when appropriate, of course, right? So it's almost like, if you show me the incentives, I'll show you the results, right? So it's not incentivized. But at the same time, we all know that talking to people, like if we say laughter is the best medicine, maybe we should say talking is the best medicine. Just educating patients to the best of our ability. And you don't always crack the code the first time, right? If you have a conversation and a patient has a certain set of firmly held beliefs, right? And but you show you're a reasonable clinician. Sometimes you don't effectuate change after that first conversation, but maybe it's after conversation 4 or 5, where finally they've heard this reiterated message and something kind of breaks. And that's the value of talking. But like I said before, it's not valued financially or clinically enough. And so at this point, I'm proficient in procedures. I'm prepared. I'm excited to be the one to do it, in as much as I know that I'm generally qualified. And if I'm not, I'll make sure that I'm finding the most qualified person to perform it. But my favorite procedure is talking to patients at this point.
That's great. I think I could say the same. That's what I love. I love schmoozing. I love schmoozing to the patients, to the
They just can't
to the
schmooze back.
parents. Oftentimes, right? But no, but I think you're right. It is a lost art. Is talking to a patient and really letting them be a patient versus you just being a doctor and telling them what they need to know, and treating them like a person, like a human being, like an individual. I think you probably do a great job of that, and it's very rewarding. But I like that answer. It's very good. But is there any follow up in what you do? Meaning, someone comes in as an emergency. Now, are you seeing them to affect you to make that change?
So that's a good question, that's a great question. And the answer is variable. The answer is, strictly speaking, as an emergency physician, generally speaking, I'm not the continuity of care doctor. But, and this is something I try and teach residents when I work in the ER. I say, even after I've finished evaluating a patient, let's say a resident's on the case and a new attending's coming on, right. I go over to the residents that are taking care of the patients that I share with them, and I say, you have my phone number? Make sure they have my phone number. I say, call me about this patient if there's an issue or if you have any questions. It's my patient, right? I think too often in emergency medicine, the phrase that people use is you meet them, greet them, meet them, treat them, and street them, right? You meet them, you say hi, you do what you have to do, and you send them on their way, which I appreciate the sentiment there as you try and take care of people as quickly as possible. But I think sometimes in that statement, there's the assumption that you don't formulate relationships and they're not really your patients. Right. And I think that's not the correct way to look at any form of medicine, and especially emergency medicine. I firmly believe that, someone can have a primary doctor for 30 years, but the most important day of their life is when they showed up to the emergency room with a heart attack, right? So out of the doctor that's known him for 30 years, the family's probably going to remember the ER doctor the most, right? So
that's very true.
I try and take ownership for my patients, and if there's anything, even after hours, I'm no longer on call. I don't get compensated for taking a call about an issue at that point in time. It doesn't matter. Call me about my patient. I want to make sure that we're on the right track. We're doing the right thing for them. So that's one aspect of the answer. Another component is we do have what you would call a frequent flyer. There are people that enjoy the care of particular emergency departments, and they return again and again. And
I
asked
want
me,
to be your patient.
they loved to be my patient the first time they came back. But actually, when you said about my favorite procedure, I was thinking about this yesterday. What my favorite procedure was, and my favorite procedure is getting warm blankets and food. In the emergency department. I'm dead serious. When patients are not feeling well and they're hungry, and sometimes it's a little cool, and like getting that fresh warm blanket from the warmer that they have in the emergency department, and that food box, and giving it to the patient, there are very few things I find as gratifying. I think I tell people that to think of themselves, I tell emergency room residents, physicians, I say, if you think about yourself as an overpaid blanket getter, right? Then you'll be happy with what you do. It's all about how you frame your experience. But if you feel like it's beneath you to get food for someone, or to clothe someone, or give them a blanket, then obviously there's a humanistic component missing to your care. And then the last way to answer your question is, certainly with what I do here, I have created some form of a following of some patients who do appreciate either the humor in the room, or the way I speak to them, or even the delicate nature of how I perform procedures. And there certainly is a repeat customer component to working here as well. And once again, I appreciate all those things. The point of this blue room, of this podcast, is that if you don't create a relationship with patients, then they're going to be lost, right? Because there's a lot of grifting. There's a lot of snake oil salesmen out there that are way more appealing than a long form conversation about a philosophy of medicine. And B, it's to get them to know literally how much we care, right? I don't have, in 10 minutes in a room, I don't have enough time to explain how much I care about that particular encounter, even when I'm tired, even when I'm hungry. But you have time when you're sitting in a chair, fortunately, to describe the level of compassion. And it's not just me. I'm sure you feel the same way. And I see many physician assistants, nurse practitioners, and doctors in this facility and in other facilities. I feel like in the past few years, because of a lot that's gone on in the world. There's been a lack of trust with clinicians in healthcare. And because of the opportunistic snake oil salesman, right, it's compounded the issue, right? So this is an opportunity to show patients we care, we are trying our best, and I want to work with them. And there's a lot of good medicine out there. There's a lot of great medicine out there. And they just we have to help them find it. And that's our job. And that's part of what we're doing here.
Right. I think you hit it right on the money. Right on the point.
Dr. Schames, thank you for coming in for part 2, aka part 1 of the Eyes Your Health podcast experience.
This is great.
This was better, so I'm glad we had the error and we had to redo it. So thank you for coming in. Okay.
Thank you for having me, and keep up the great work you're doing.
Keep fixing the teeth. Okay.
Pleasure.
All right. Thanks for coming in.